everyone, I'm Soosan Jacob, and in this video we see that as I'm trying to create the PDEK bubble, a type 2 bubble forms in the periphery and pops, and that's a replay of the same scene again. So what I do now is I introduce the needle from the opposite side, this time with the syringe carrying viscoelastic, and I dissect out a type 1 bubble using viscoelastic. Now when you use viscoelastic, it's a much more controlled procedure, and as the bubble starts to form, I need to keep the type 1 and the type 2 bubble from joining up together. For this reason, I have used a tying forceps or a McPherson to separate the type 1 bubble which is forming from the type 2 which had formed earlier and burst. Now the mechanical pressure that's applied by the McPherson does not allow the type 1 to expand in that direction and preferentially makes it expand in the opposite direction. The bubble size is roughly estimated, and if it is found to be small, it can be enlarged slightly further, but taking great care and being prudent to not aim for a too large bubble which might pop during the procedure. Once you've got an adequately sized bubble, the bubble space is entered into using a 15-degree sideport blade, and then the bubble is cut all around with a Vannas scissors, with the blades being held horizontally in order to avoid endothelial damage as much as possible. The bubble is cut at the extreme periphery, and once the graft has been dissected, it is put into the storage medium until it's ready for injection into the eye. Now, as can be seen, this is a patient with aphakic bullous keratopathy with a preoperative best corrected visual acuity of counting fingers. Since it is aphakic, I am also planning to glue in an intraocular lens at the same time, and for this purpose I have created two flaps that are 180 degrees opposite to each other. I have also inserted an anterior chamber maintainer and have made 23 gauge sclerotomies under the scleral flaps. I do a 23 gauge vitrectomy through the sclerotomy, and once the vitreous has been cleared up to some extent, we make a main port, and now what I am doing is injecting a 3-piece intraocular lens into the eye. But as I try to bring out the leading haptic, the haptic slips from my microforceps which was introduced through the sclerotomy. So now I regrasp the haptic and using a handshake maneuver, keep transferring it from hand to hand until I have grasped the haptic at the extreme tip with the microforceps to bring it out uneventfully through the sclerotomy. So we grasp it at the extreme tip, and once this is done, it is brought out without snagging on the sclerotomy, and the trailing haptic is also similarly fed into a microforceps, and using the handshake technique, this too is exteriorized out through the second sclerotomy. Once both the haptics are exteriorized, intrascleral chariot tunnels are made at the edge of the scleral flap with 26 gauge needles, and the haptics are tucked into the tunnel. This makes the intraocular lens very stable, and now what I am doing is an iridoplasty in order to achieve a stable iris IOL diaphragm. This is very important in order to be able to achieve a good airfill once the graft has been injected into the eye and floated up. A poor airfill can lead to a graft dislocation in the postoperative period, and therefore this step is extremely crucial, and getting a stable iris IOL diaphragm is part of the secret to the success of a good surgery. Now what I am doing now is what I call as the air pump assisted PDEK, and what I have done is connected the anterior chamber maintainer to an air pump, and this continuous pressurized air that goes into the anterior chamber helps me to create a very well controlled Descemetorhexis for the host Descemet's membrane, and the Descemet's does not float around in an uncontrolled manner or flap around in an uncontrolled manner within the anterior chamber. Once the Descemetorhexis has been completed all around, the host Descemet's is removed, and the donor Descemet's and dua layer, which constitutes the PDEK graft, is loaded into the injector. The PDEK graft was first described by Professor Amar Agarwal and Professor Dua, and the procedure was described by them. The e-PDEK or the endo-illuminator assisted PDEK was described by me, and it involves basically using the endo-illuminator that's used in a vitreoretinal surgery in order to enhance the ease of surgery. I first used the endo-illuminator in DMEK, and we termed it as e-DMEK or endo-illuminator assisted DMEK in order to enhance the three-dimensional perception of the graft. Now once the graft has been injected into the anterior chamber using the injector system as described by Dr. Francis Price, we can see that under the microscope there's very poor visualization, but as soon as the e-PDEK technique is used, the visualization becomes very clear, and you get a very good three-dimensional perception of the graft, which helps in confirming the orientation of the graft as well as the position of the graft in the anterior chamber. The entire graft can be seen at the same time, and this helps carry out surgery in a much more non-touch manner and contributes to lesser endothelial loss. Once the graft has been opened up, it is floated up using a bubble of air that is injected under the graft, And at this point, again, we turn back to our air pump assisted PDEK, which continuously infuses air again. And under this well maintained anterior chamber, which is being infused with air by the air pump, the graft is carefully positioned centrally in case it was not at the initial flotation, and all any creases in the graft are ironed out. All maneuvering is done on the extreme periphery of the graft, and right now what you can see is I'm going above the graft, between the stroma and the graft, to open out a fold that was there in the graft edge. Now once the graft has thus been completely opened up and centered, the anterior chamber maintainer with air infusion is removed, and all the incisions are sutured up in a tight manner, and a good airfill is ensured. Intraocular pressure is checked, and light perception for the patient is checked, and the scleral flap and conjunctiva are also closed with fibrin glue. Clear corneal incisions may also be sealed with glue, and this is the patient at the end of surgery. We also see the patient again at 2 months post-operative with a much clearer cornea, and patient now has a best corrected visual acuity of 6/18 as compared to the visual acuity of counting fingers close to face that he had presented with at the time of initial presentation. Thank you so much for watching. I hope you enjoyed this video.